Hi, I am Alfredo Castro, and today I'm going to talk to you about the refining antithrombotic therapy for atrial fibrillation and acute coronary syndromes. Definition: antithrombotic are medicines that reduce the risk of heart attack, stroke, and blockage of the artery and veins by preventing blood clots from forming or enlarging. There are two main types of antithrombotic therapy: anticoagulants and antiplatelets. Designing the optimal antithrombotic treatment for a patient with atrial fibrillation and PCI, with or without acute coronary syndromes, is a challenge that we frequently face in clinical practice.
Triple antithrombotic therapy is the standard of care for patients with atrial fibrillation undergoing percutaneous coronary intervention, or PCI, with stenting. Oral anticoagulation and dual antiplatelet therapy with a P2Y12 inhibitor plus aspirin are used to prevent thromboembolic events, including stroke, systemic emboli, and stent thromboses, but they are associated with a high risk of major bleeding. A potential therapeutic strategy to reduce thromboembolic events and bleeding risk is dual therapy, with the oral direct thrombin inhibitor dabigatran and a P2Y12 inhibitor without aspirin. In the multicenter randomized redual PCI trial, 2,725 patients with non-valvular atrial fibrillation who had undergone PCI with stent implantation within the previous 120 hours were randomized to receive either triple therapy with warfarin, a P2Y12 inhibitor, either clopidogrel or ticagrelor, and aspirin for 1 to 3 months, or dual therapy with dabigatran, 110 or 150 milligrams twice daily, and a P2Y12 inhibitor. The primary endpoint was time to first major or clinically relevant non-major bleeding within 14 months. The rate of major or clinically relevant non-major bleeding was 15.4% in patients receiving 110 mg dabigatran dual therapy, as compared with 26.9% in patients receiving warfarin triple therapy. Similarly, the rate of major or clinically relevant non-major bleeding was significantly lower in patients receiving 150 mg dabigatran dual therapy than in those receiving warfarin triple therapy. In the secondary endpoints, there was no significant difference in the rate of thromboembolic events or death between patients receiving 110 or 150 mg dabigatran dual therapy and those receiving warfarin triple therapy. The authors conclude that in patients with atrial fibrillation after PCI, dual therapy dabigatran and a P2Y12 inhibitor significantly reduced the risk of bleeding as compared with warfarin triple therapy, with no increase in thrombotic complications. Full trial results are available at nejm.org.
Application in medicine. The main indication for a patient to receive vitamin K agonism are as follows: mechanical valve prosthesis, atrial fibrillation, deep vein thrombosis, um, pulmonary embolism, myocardial infarction, and acute ischemic stroke. Currently, the use of antithrombotic therapy in our country has allowed the incidence of case of cerebrovascular diseases to be reduced. Pros and cons. Pros: demonstrate an evidence superiority in terms of, reduce of the major or fatal bleeding with the use of dual antithrombotic therapy. Cons: the main element against antithrombotic therapy is it can generate a high predisposition to presence of a possible hemorrhage, especially in patients who were admitted for ischemic cerebrovascular diseases. Conclusion: antithrombotic are drugs that reduce the risk of a cardiac arrest, thromboembolism, and coronary heart diseases. There are two types of antithrombotic therapy, and their main risk is the presence of red bleeding in the cases of ischemic. Thanks.
Well, it's been an interesting time in the last 2 years in patients who have atrial fibrillation who need to go under PCI in getting new data to help address what should be the antithrombotic mix. And following the WOOS trial, we have done studies where we dare to stop aspirin, and that looks like it's a smart answer. The concept is that using triple therapy with aspirin, a P2Y12 inhibitor, and an anticoagulant is needed for the atrial fibrillation and the stent, and yet it leads to a lot of bleeding. And so the idea is, could you take away the aspirin and have less bleeding and still get away with that from a thrombotic point of view? And the answer seems to be yes, so that WOOST and Pioneer AF and then Redual PCI all found less bleeding when you take away aspirin, and so have dual therapy with a P2Y12 inhibitor and, in the latter cases, a novel oral anticoagulant. Fortunately, the thrombotic events don't seem to be increased even when taking away aspirin. So you use aspirin obviously before PCI in the hospital, but then at discharge stop it. And we saw in Redual PCI like 30 to 50% lower risk of major bleeding and similar rates of thrombotic events. We studied dabigatran in Redual PCI, and the approved dose of 150 milligrams had just identical rates of stent thrombosis, MI, etc. So full dose anticoagulation, P2Y12 inhibitor, usually clopidogrel, although we had some ticagrelor, but then no aspirin, and the outcomes were really terrific. And so a recent North American consensus statement, I was a part of it, about 15 of us, did note that with now 3 trials showing this, that this could be sort of the default strategy, that after or at the time of discharge that you'd send people home on the dual therapy and allow risk stratification. If you had a high thrombotic risk, a left main stent or something, I think maybe a month or more of triple therapy, but to really shift towards this dual therapy as the default. And so we'll see how that plays out. There are some new trials coming, but that does seem to be a nice advantage that we can offer to patients and really reduce bleeding for them.